Hello everyone, and welcome to this audio podcast. Today. This audio podcast is part of the conglomerate. This audio podcast is part of a lobostic storm. This audio podcast is part of a Storm and Battle and Chronicle. This audio podcast is part of the Ztormish series or edition, and this audio podcast is part of a Storm Lobostics production. Through this audio podcast today, a look at sort of hereditary forms of two sort of hereditary forms of two hereditary forms of kidney diseases, or hereditary diseases or conditions that have a basis of in around particular and specific genetics, and also in around particular where molecular level there is or can be sort of abnormality. So today through this audio podcast, I look at in a excuse me, I look at two particular conditions. One being autosomal dominant polycystic kidney disease, and the other being autosomal recessive polycystic kidney disease. In around the content, in around sort of the overview of this audio podcast, there'll be a look at autosomal dominant polycystic kidney disease, and then there'll be a look at autosomal dominant polycystic kidney disease versus autosomal recessive polycystic kidney disease, or ADPKD, versus ARPKD. And then I look at sort of the pathogenesis. I look at clinical management of ADPKD. I look at some of the diagnosis. I look at ADPKD complications. I look at ADPKD disease progression. I look at microbial infections, links between microbial infections and ADPKD progression, and clinical trials, in around clinical trials, and then a summary. So to begin with, one of the most in around ADPKD, one of the most frequent inherited sort of disorders or conditions in amongst the adult healthcare population, healthcare population. The fourth cause of renal anomalies in around globally. It affects 60,000 recipients in the United Kingdom, about 600,000 in the United States, and an estimated about 10 million globally. ADPKD affects 1 per 400 to 100,000 people, and about 7 in 10 recipients with ADPKD progress into renal insufficiency. Result of germline mutations in PKD1 and PKD2 genes form a part of the molecular investigations, and those genes encode for polycystin 1 and polycystin 2. Now looking at sort of the differentiation, if you like, between ADPKD and ARPKD. So in ADPKD, is typically there's an adult onset. The mutations are in PKD1 in around more than 80%, or PKD2 and more than 15%. There are cystic kidneys and all nephron levels, but mainly in amongst distal regions of and part of the nephrons. Bile ducts and liver are also can also be affected. Abnormalities in ABP, arterial blood pressure, in at least 20 to 40% of children and young people, and in most adult recipients is evidence or has been evidenced in amongst literature before GFR, glomerular filtration rate decline, and that intracranial can be intracranial aneurysms in more than 8% of recipients, and where there's an increase threefold in recipients with positive family history, and ESRD in around 50% of recipients of 60 years of age. So in ARPKD, typically is a pediatric or young people onset mutations. There are mutations in PKHD1 and ZIP1L. Cystic kidneys, collecting ducts, and distal tubules and bile ducts are and can be implicated. There's hepatic fibrosis. There's abnormalities in around ABP, arterial blood pressure in around up to 75% of children and young people, and often during the first few months of life. Intracranial aneurysms are only described or have only been described in sort of case reports. ESRD or ASKD in 60% of recipients is or has been evidenced by whereby recipients are affected by the age of 20 years of age. In around the pathogenesis, due to mutations in PKD1 and PKD2 genes, cell polarity is disturbed, and epidermal growth factor receptor is expressed, and it is increased, and then stimulation of cell proliferation through mechanism involving intracellular signaling, such as RAS and RAF, and MEK and ERK. ERK are proliferated. And as part of ADPKD complications, so complications of ADPKD include complications have mechanisms, and whether in around the different mechanisms there are prevalences, and then available pharmacotherapeutics that help some of the symptomologies in around ADPKD. So in around the complications, there are liver cysts. There is general pain, pain or discomfort in around particular parts of renal pathophysiology. There's abnormalities in ABP. There's in amongst literature there has been data to inform of seminal vesicle cysts, nephrolithiasis, and or renal calculi, hematuria, and intracranial aneurysms, and pancreatic cysts in addition. In as part of the mechanistics, in as part of liver cysts, there is an increased cyst burden, typically coinciding with increasing age. In as part of the pain in around renal pathophysiology, there can be dynamic cysts, cyst enlargement, rupture, or infection. In as part of ABP abnormalities, there is increased renin-angiotensin aldosterone system activation, In as part of seminal vesicle cysts, there are obstructions in obstructions where there's potential where there can be implications for male infertility. In around nephrolithiasis and renal calculi, there is renal stasis and renal injury due to cyst enlargement. In around hematuria and nephrolithiasis, cyst rupture and or hemorrhage infection. In around intracranial aneurysms, there can be altered hemodynamic status and cyst rupture. In around pancreatic cysts, there can be cyst-mediated obstructions, cyst-mediated obstruction potentiating pancreatitis. In as part of the sort of prevalences in around liver cysts is around 83 to 94%. In around the sort of ADPKD sort of pain and where pain is aligned to dynamic cyst or cyst enlargement and rupture. Excuse me, or a rupture or infection. The prevalence in around the lower back is around 71%. In around the abdomen, around 61%. In around the head, around 49%, and around the chest, around 30%. In around ABP, arterial blood pressure abnormalities or anomalies, there is a prevalence in around 60%. In around seminal vesicle cysts, there is prevalence in around 40%, and infertility, or where infertility has been where infertility is amongst has been in amongst the literature. At the same time, the prevalence in around the specificity is unknown. In around nephrolithiasis and renal calculi, the prevalence is in around 10 to 35%. In around hematuria, the prevalence is in around 11 to 16%. In around intracranial aneurysms, the prevalence is in around 10 or 25%, 10 to 25% in cases of positive family history. And then in around pancreatic cysts, the prevalence is in around 9%. For the purposes of this audio podcast, owing to the advances in particular pharmacotherapeutics, the sort of available treatments or pharmacotherapeutics will not be mentioned, since literature will have sort of more informed pharmacotherapeutics data. In as part of ADPKD disease progression, laboratory monitoring includes a sort of creatinine levels and estimated glomerular filtration rate investigations, presence of fluid-filled cysts, and enlargement of the total kidney volume, or TKV. Additionally, progressive cyst formation and reduction of renal function leads to where it can lead to ESKD or ESRD, and there is literature to inform in around the pathophysiology where there's comparisons between normal renal pathophysiology and PKD, ADPKD pathophysiology, and in ADPKD pathophysiology there is literature to that sort of goes into cyst, a look into cyst development and the implications of cysts and around the cyst development and enlargement. In around sort of the microbial infections now, the prevalence of urinary tract infection is frequent and severe in complicated cases of ADPKD, and had been observed in 3 to 50% of ADPKD or recipients. Cyst infections lead to hospitalization, and approximately 9% of ADPKD recipients and 26% of reported recipients on KRT or RRT. Evidence suggests that cyst infection is amongst one of the most important or crucial factors for ADPKD progression and decrease in renal function or renal insufficiency. The issue of cyst infection has received minimal attention in amongst literature. E. coli, Klebsiella, and Enterococcus are the most often causative agent of cyst infections. The endotoxin of gram-negative bacteria has a vital base in the dysfunction of organs, including renal pathophysiology. Looking at sort of links between infections and ADPKD progression. So asymptomatic pyuria and UTI can have an impact on renal functions or renal anomalies in renal pathophysiology in ADPKD recipients. Asymptomatic pyuria observed in a third of has been observed in a third of ADPKD recipients. Observed associations between UTIs, renal function decline, and TKV and PKD gene mutation have been evidenced. ADPKD patients or recipients with UTI with lower EGFR than those without UTI is in amongst the literature. TKV significantly increased in ADPKD recipients burdened with UTI versus ADPKD recipients without infection, and PKD1 mutations is or has been associated with increased increased TKV in ADPKD recipients. In a kidney disease improving global outcomes, or KDIGO guideline, looking at a scope of work for KDIGO clinical practice guideline for the evaluation and management and treatment of ADPKD, the diagnostic criteria and methods of treatment options for cyst infection are not well defined. Investigation of TKV and ADPKD patients burdened with infections can help in the prediction, in some of the prediction of multiple UTIs and disease progression. In amongst sort of an overview of ADPKD and clinical trials, so there have been clinical trials looking at different aspects interlinked with ADPKD, and where literature informs in around for example the sort of outcome measures, both primary and secondary. For the purposes of this audio podcast, there will not be an overview in looking at ADPKD clinical trials, since different clinical trials and data in amongst the literature would be more in more recent literature would be more informed. And finally, looking at a summary, A summary. Formation of fluid-filled cysts is a hallmark of ADPKD, and the way the disorders are devastating renal and extrarenal manifestations. Are and can be implicated. ADPKD is an important genetic cause of CKD that should be considered in recipients less than 50 years of age who also represent with onset anomalies in around ABP, macroscopic hematuria, and or impaired renal insufficiency. A so-called cure for ADPKD remains remains a sort of optimistic basis. Literature informs or has informed tolvaptan pharmacotherapy has been a sort of a pharmacotherapeutic agent, a pharmacotherapeutic agent for ADPKD, having been shown to delay TKV expansion and renal insufficiency in a particular clinical trial in amongst evidence and literature. Cyst infection is a common complication in ADPKD. Diagnostic criteria and methods of treatment options are limited and are not well defined or evidenced. Currently, fluoroquinolones sort of as antibiotics. Antibiotics have been of choice in the treatment of cyst infections because are characterized with sort of good intracystic penetration and broad spectrum activity. Investigated research around ADPKD displayed that there is a need for broader and more collaborative efforts. That draws this audio podcast to a close. This audio podcast as part of the conglomerate. This audio podcast is part of a Lobostic Shystorm. This audio podcast is part of a Storm and Battle and Chronicle. This audio podcast is part of the Ztormish series or edition, and this audio podcast as part of a Storm Lobostics production.